much do we have to overcome psychologically, sociologically, to help patients and consumers see their role and understand their own sense of power?
Personally, you know, the first time I went to Washington 15 years ago, I remember thinking, oh my gosh, these people speak a different language. You know, it's a language barrier. I'm from the south side of Indianapolis. I don't speak Washington, D.C., you know. And I would say that that same language barrier also happens between the patient and the physician. And, you know, we actually have a study that was supported by the CDC through a partnership with ENACT, where we really looked at patients and the conversations that they had with their healthcare professionals and created a program to really help facilitate that dialogue. And what we learned in that study was that the patients felt like they were not prepared to come to their appointments, that they were having conversations and language was being used that they didn't really understand, and the time frame was so quick that they didn't have a chance to really process what was being said or what decisions they would make. You know, and so in the same way that we've created tools to help with that, you know, and educate patients before they see their physicians, it's the same thing that you do on Capitol Hill. You know, you go to Capitol Hill and they're using words like cloture and, you know, you hear bells ringing on the Hill, and what does this mean? Is it a fire alarm, or is it a vote, or, you know, what are all of those things? When you look at the barriers that exist, there's real parallels between those. So when you talk about somebody being a personal advocate for your own health or a broader advocate for the good of the public, that's a real opportunity for us to make significant change.
I also see a very unique opportunity for all of our organizations when we talk about patient organizations, provider organizations, to be ambassadors for patients. And I think in many of the cancer communities in which we work, it's interesting that you don't often see a roadmap or a journey of what a patient goes throughout that continuum of care, the access issues, the treatment issues, the various barriers and family stressors and variety of challenges that they go through. And I think the more that we can do together as patient and provider organizations to almost, I guess, blaze that trail for them, maybe is the best way to say it, and paint that picture, I think that the better that we're doing to better serve patients and survivors, particularly because I think that journey and that roadmap hasn't been clearly laid out for a lot of cancers. And I think maybe that's the next generation of our organizations working collaboratively.
I think that we took an oath. Ultimately, we took an oath. And we the physicians that care for patients or cancer patients, agreed to become patient advocates on a very personal level. And if a physician is not living up to that standard, then he or she is performing at a woefully inadequate level. That's not an ASCO public policy position, but it's a personal position. I think that what we do in my office, what we meaning me and my patient and their family members, is that I see my job as a person who is in a position to provide information first and advice second, so that my patient, regardless of their station in life, has enough information to participate in what I call shared decision making. And if we can't together reach a reasonable conclusion about the proper course of action to take, then at that point we don't have a productive patient-physician relationship. And so I think that all doctors on some level, that's the final common pathway there, is that doctors and patients on a very personal level have to come together and make good decisions. But in a broader sense, from a, you know, that's a very granular, feet on the ground position. But from the 30, 40,000 foot perspective, we are also challenged to be advocates in a broader sense, in the public arena, and the bigger issues that affect not just the patient in the room with us, but the aggregate group of patients, or the citizenry as a group. We talked about oral parity. We're concerned at ASCO about healthcare parity. We saw a slide at the opening session yesterday that indicates that if you have Medicaid, your chance of surviving cancer, the survival curve, is only marginally better than a patient who is totally without any financial resources. And so we're very concerned that everybody, every patient, regardless of their station in life, has access to high-quality cancer care and can get the best that we as cancer physicians have to offer.
I think patients move into the medical setting with a predisposed attitude that the physician knows best. The physician is the expert. And indeed, often the physician does know best. But the consumer has to feel that there's a liberty waiting for them in that examining room that says, this is an open door discussion. There are two sides to it. We as patients can ask the questions. Physicians can answer the questions. And right now, we're dealing with a framework of reimbursement in the United States that does not necessarily incent that. If a doctor knows in a capitated contract they have 15 minutes in the room with that patient, or they have 10 minutes in the room with that patient, it's really difficult to have that conversation. So I think a lot of this begins with physicians talking with patients and saying the best way for us to get through this is to do it together and to have really good conversations. And the best way for patients is to greet their doctor and be able to say, I'd really like to partner with you in my health care here and like to be able to ask you my questions.
I really thank you, because for Vital Options too, it's a privilege to be a part of facilitating a dialogue amongst all of you.
Great.
Thank you.
Thank you.
Thanks for having us.